Good day to all the participants and speakers. Welcome to Anesthesia Patient Safety Symposium 2023. I'm Dr. Teo, pediatric anesthesiologist from Sarawak General Hospital. It's my honor to introduce our second speaker today, Dr. Jeffrey Cooper, who is professor of anesthesia at Harvard Medical School and Massachusetts General Hospital. He is engineer in training. He's the founder, executive director emeritus, and senior fellow of the Center for Medical Simulation in Boston. Dr. Cooper is one of the pioneers in patient safety with landmark research done in medical errors in 1970s and is the co-founder of the Anesthesia Patient Safety Foundation, as we saw earlier in Dr. Cole's slide. Interestingly, he was for many years the director of biomedical engineering at Massachusetts General Hospital and then Partners Healthcare System. He has received multiple honors and awards for his work in patient safety and authored or co-authored over 150 peer-reviewed articles and book chapters. Dr. Cooper today will be talking to us about promoting a culture of anesthetic critical incident reporting, impact on safety culture and patient safety. There will be a short Q&A session at the end of his talk. If you have any questions, please put it down in the Q&A box on the right screen under live discussion. Now, let us listen from Dr. Jeffrey Cooper.
Hello, everybody. Good morning, afternoon, evening, or night, depending on where you are or what time you're watching this. I can't tell you what an honor and a privilege it is for me to be one of the people presenting here at the first Anesthesia Patient Safety Symposium. As some of you may know, I was in the room when we organized APSF in 1985. I'm absolutely thrilled that APSF continues to be so vibrant, doing so many wonderful things for anesthesia patient safety, including helping to organize this meeting. I'm going to share my screen. I'm happy to be talking with you about this topic that I was asked to present. That is the topic of the question of, is reporting anesthesia critical and safety events useful? I suspect most of you are in organizations where critical incidents and safety events are reported. I think it happens in healthcare organizations and all over the world. But there's some interesting questions about that. And there are four questions that I'm going to focus on in this presentation. First, is incident reporting useful in healthcare now? How does the culture affect the reporting? And also, how is the reporting how does it affect the culture? It goes both ways. And specifically, what's required for incident reporting to be useful? Again, I think we take it for granted. It happens everywhere, but there's really a question about what we get from it, and I'm going to address that. First, let's have a couple of definitions. First, I'm calling an incident any event which could have reduced or did reduce the safety margin for the patient. This comes from an article in 2009. There are other incident definitions, but I think this really captures it. There's another common term that's used, that is a PSRS, a patient safety reporting system, and I may be mentioning that as well in this talk. Let me tell you a little bit how I got started in this, and maybe it's why people ask me to give this talk, because they see this as a topic that's important to me, and it is, although I haven't been deeply involved in the actual study of incidents lately, or that is of the reporting of them. We got involved in this back in the early 70s, somewhere around 1973. And we published this article in 1978. It was a landmark article about preventable anesthesia mishaps. We used the critical incident technique, which is a technique that was popularized, published in 1954. Basically, it's used to study any kind of a problem, positive or negative events. We used it to study problems in anesthesia. We asked anesthesiologists and residents and nurse anesthetists what were their experiences of events that they had either mistakes that they had either made or observed, and we collected those and we looked at those stories, and this was the beginning of my involvement in patient safety. There were several articles after that, but this is where the idea of critical incidents really was presented for anesthesia. There actually was a article about incidents a few years ago in medication errors, but not in anesthesia. So this is, I think, where the term comes from in anesthesia, and again, how I got involved. Back then, we called a critical incident any occurrence that has led or could lead, if not discovered and corrected in time, to an undesirable outcome. That's a very specific definition when you're studying critical incidents, when you're doing research, which is a little bit different than the actual reporting process. There are lots of other anesthesia studies using the critical incident technique and critical incident reporting. In 1993, the Australian Anesthesia Incident Monitoring System went into play. There have been several articles from that. There have been incident reporting studies in Malaysia and Singapore, New Zealand, the UK. There are systems in Denmark, in the US, the Anesthesia Incident Reporting System. It started in 2008, and there are regular publications about those events in the American Society of Anesthesiologists publication Monitor. The Netherlands and Germany also have incident reporting systems, and there are many others. Many of these noted here were published in an article by Choi in 2008. So the idea of having reporting systems is pretty common. These are national reporting systems, which are really a bit different. These are for identifying larger issues and national trends. What I want to focus on is local incident reporting. There's how do you use incidents to fix local problems and also to fix the systems and improve the patient safety culture. So this is an example of a national reporting system, by the way. This is the National Reporting and Learning System in the UK. But again, that's not what I'll be concentrating on. It's more about the local system. So let's talk a little bit next about culture, because I want to talk about this relationship between incident reporting and culture. Culture is the product of individual and group values, attitudes, competencies, and patterns of behavior that determine the commitment to and the style and proficiency of an organization's health and safety programs. This comes from the paper that's cited there from 2011 in BMJ Quality and Safety. Now, we can't really measure culture. There's controversy about this, but I'm on the side that says you can't really measure a culture. Culture is really the way we go about doing things, how we do things around here in an organization. What we generally can measure is the climate, the safety, the surface features of the safety culture from the attitudes and the perceptions of individuals at a given point in time, or the measurable components of safety culture. So we can't really measure the culture. We're measuring some kind of a surface feature, some manifestation of it. So what's a good safety culture look like? We'd all like to be in a great safety culture. What is that? Well, organizations with a positive safety culture are characterized by communications founded on mutual trust, by shared perceptions of the importance of safety, and by confidence in the efficacy of preventive measures. This comes from a BMJ, another article, this is in 2011. Again, there are other definitions about safety culture. I think this generally captures this idea of what is a safety culture. Now, there are values that safety cultures have. Let's talk about those. There are lots of attributes of safety cultures. I'm just going to talk about a bit of that so we can be thinking about how does the culture relate to the incident reporting? How does one affect the other? First, in a good safety culture, safety is number one. It's what people think about. It's the first thing. It's not about production. It's we make sure that nobody's supposed to get hurt. There's a preoccupation with failure. People really worry about things going wrong. Can somebody get hurt? Can people make mistakes? They're preoccupied with it in a good safety culture. And resources are provided for safety. It's not just talked about. Resources in terms of people and the means to create good procedures and policy and processes so that the system is safe. So in a safe culture, people feel safe in reporting their concerns. The safety issues are acted upon, and the patients and employees don't get hurt. It's really kind of basic and simple. People feel safe to report. When something happens, people try to fix it. They work hard to fix it, and people don't get hurt when the culture is a safe one. So let's talk about what a local safety reporting and response system looks like. This is something like a PDSA cycle that you're probably familiar with. You probably are familiar with aspects of this. I put this, what's a bit of a complicated flow diagram together, but I want you to be thinking about what does a full, robust reporting system and action system look like. First, the reporting, when people report, it's non-punitive. The culture is such that people know if they report, they're not going to be blamed, even when they report something where they weren't quite correct about what the reporting is. There's no retribution for reporting in a good safety reporting system. There's feedback to the reporters. When they make a report, they hear that something happened, that somebody got it, and that something's going to happen about it. There's an investigation. There's an analysis. There's naming or labeling of what that event was and how it fits in with other events. And there's often feedback at this point that the reporters get to hear that, yes, we've investigated this. We analyzed it. This is what we're going to be doing about it. There's also trend identification, not just one event being looked at a time, but they're collected and the trends are looked at to see what kinds of fixes can be made from the trends, not just about the single event. Remediations are recommended. Fixes are recommended for either an individual event or a trend. The trend of identification also feeds into the remediation creation process. When the fix, the remediation is designed, it should be simulated. It should be tried out before it's actually put into action. There's an implementation process activated. There is a system, there is expertise in how you take the remediations, the fixes, and you put them into practice. You measure the change. You see if your change, what you did, made a difference. You feed that back into the implementation process and you make corrections. You disseminate the learning widely. Don't just keep it to yourself, but you let people know, we learned from this event. This is what we did about it, and this is how things have gotten better. And in a good system, we know that harm is prevented. That's the first main goal, but there's a second goal. And that's that there is also positive culture change. When people see that their reports go from investigation and to fixing and to change and to preventing harm, presumably the culture gets better. Because people know, people care about safety, the leaders care about safety, and their concerns and the bad things that happen are taken seriously. There's also feedback to the reporter, and there's when you disseminate both the feedback to the reporter, and the dissemination also feedback into positive culture change, and that positive culture change presumably also works to prevent more harm. So this is something of a complete system. There are other diagrams like this. There are other details, but this is really the heart of it, of the kinds of things you have to do to have a complete local safety reporting and response system. But the problem is, what usually happens is most of the resources go to reporting. It may or may not be non-punitive, but because once people start reporting, the resources really have to pay attention to the reports and to investigate them. That's where a lot of the effort goes, to collecting the information and investigating and analyzing and naming it. And there's much less on remediation. There may be some remediations proposed, but often this loop really isn't closed, because the hardest thing to do is to put changes into system and sustain those and actually get the culture to change. So that's really a downside of most of the reporting that goes on today, I think, and that's what we're going to focus on here. So how does the safety culture impact the incident reporting? This is just a concept. There is some data about this, and I'll talk about this. When there is a positive safety culture, it acts to increase the incident reporting. That is, when people feel safe and they know their reports are acted upon, they're going to report more often because they feel like they're in a good safety culture. The reverse is true too. If you have a dysfunctional safety culture, you instead have generally lower incident reporting. There's some information to suggest in some cases that's not entirely true, but just imagine it. When people put the reports into the system, they don't hear about it, nothing really happens. They're generally less likely to report safety events. So these kinds of things happen that prevent incident reporting from being really effective. So what are the factors that affect the frequency of event reporting in hospitals and other healthcare organizations? There actually is some literature about this. This one comes from a publication in 2015 on a hospital survey on patient safety culture. It used the AHRQ hospital patient reporting the survey, the culture survey from the 220,000 employees in 967 hospitals in the US. The cultural elements from that survey that were correlated with increased reporting, that is, when people reported in the survey that they reported more, they also reported that it's because they got feedback about their errors, that there was management support for patient safety, there was organizational learning, there was a non-punitive response to error, and there was teamwork within the units. These were things that influenced higher incident reporting. There's another study in a NICU in 2009 from the 8 Dutch NICUs, also the AHRQ culture survey, they implemented a non-punitive reporting system. There are 4 of the units that already had an incident reporting system that was somewhat non-punitive, and they added 4 more. And what they found was that the increase in reporting was associated with, again, a perception of non-punitive reporting in the survey response. They actually had a negative perception of overall, where there was a negative perception of overall safety and hospital management support for safety. At least my interpretation of this study is they actually had more reporting, which I think is counterintuitive, but that's what I think this particular study said. I mention this because it points out that the data aren't entirely clear, but there are studies about this question, again, of the relationship between the safety culture and the frequency of incident reporting. So in another study about incident reporting system effectiveness, there were a review of 43 studies of incident reporting. There's some evidence that an IRS, a PSRS, produces single loop learning. That is, there's a specific learning from that event, but there's little evidence of outcome change or double loop learning. That is, that there are broader changes from a single event or a trend of events. There's culture or mindset change, not that there's just a fix for that specific event. So the advice from this study was we need to be more explicit about what counts as an incident. It's got to be made clear to people. And that the clinical team should own and lead the investigation, not just people who are remote from the clinical world. And you have to embed the incident reporting system and its investigation and analysis into an organizational safety program. It should be part of the whole organization safety program, not just stand on its own. And again, this comes from a study in 2015. So generally speaking, why isn't incident reporting working as we all hoped that it would? This is from a paper by Mitchell about patient safety incident reporting. And their analysis suggests that there's poor processing of the events. There's inadequate engagement of physicians in general in incident reporting systems and the full feedback loop. There's insufficient visible action. That is, the reporters really don't get to see what happens. And there's inadequate funding and institutional support, as was mentioned before. And in this study, this report, they advised that there's inadequate use of information technology in the whole process of reporting and managing events. I'm not sure how true that still is today. I mean, this was 2016. I know in our own hospital, we do actively use IT systems for incident reporting, and it's very effective. Now, their conclusion was, if the healthcare industry wants to learn from its mistakes, miss or near miss events, it will need to take incident reporting as seriously as the health budget. Now, that's a tall order because we know how important the budget is. There's no margin, no mission. That is, it's really important that the healthcare system remain financially viable. So it's a challenge, but if incident reports and patient safety really are to take the priority they deserve to make sure that nobody gets hurt, then you've got to take incident reporting and the full process as seriously as you take the budget. And this is from the Mitchell study that I cited earlier. Now, there's a problem with incident reporting that you're probably all aware of, that sometimes incident reporting is used wrongfully. It's used as a weapon. People sometimes will file an incident report to get back at somebody or to blame somebody for something, rather than using it for its real intent to report safety problems. So in an article by Bradley in the ASA Monitor, the quote is, "These reports may inadvertently lead to a worsening of safety culture by eroding trust and respect among healthcare professionals and teams, which affects both patient safety and individual well-being." That is, when people use incident reporting as a weapon, it's a negative thing for safety culture. Another article in the Journal of Graduate Medical Education was titled "Gotcha: Using Patient Safety Event Reports to Report People Rather Than Problems." And the quote there is that safety reporting can insidiously produce a culture of blame as opposed to a culture of safety. So this is something that really has to be worked on, that people have to be taught the right way to use incident reporting systems, not to use it as a weapon, not to use it to go after people. If you're having an issue with somebody, you've got to find other ways to deal with that than filing a safety report to try to get them in trouble. So this is a little graph or a little animation that is the opposite question we talked about before, and that is, how does incident reporting, or how may it affect the safety culture? There's really not empirical data about this. This is really more of anecdotally based and generally a gut feeling that when you have an effective incident reporting system, it probably improves the safety culture for all the reasons we've talked about. And the opposite is probably true too. If it's a dysfunctional incident reporting system and people are weaponizing it, and the whole system really isn't working well to close the loop and do things appropriately, that dysfunctional incident reporting system probably has a negative effect on safety culture. And we really want to do the opposite. We want incident reporting to be robust, to make changes, make them visible, and prevent harm, and not be weaponized. So what are the elements of an effective incident reporting system? Some of this is review, but it's really important to carefully think about this. And I'd like you to be thinking about, in your own system, what is the incident reporting system like? Does it have these elements? Are there clear definitions of what to report? Do real people really know what they should and shouldn't report about safety events? Is there some kind of a severity scale? Do you prioritize what's investigated? This is really important because in an effective system, there are so many safety reports, many of them minor, that you've really got to be thoughtful to prioritize what are the things that we investigate deeply and do a root cause analysis for. And you have to have an effective analysis process. The root cause analysis, RCA2, is really the most popular, but you have to go beyond that. And one way to do that is to use the newer system, the RCA squared, that includes the second A for action. We're going to talk about this. These elements in an effective system were mentioned in another article here in 2021 in Clinical Anesthesiology. I hope most of you have heard about RCA squared, root cause analysis and action. This was published by the National Patient Safety Foundation, which has since been integrated into the Institute for Healthcare Improvement. And this is a report from MPSF in 2015 on improving root cause analysis and actions to prevent harm. And it describes RCA squared. And the focus is on this statement, that the most important step in the RCA process is the identification and implementation of actions to eliminate or control system hazards or vulnerabilities that have been identified in the contributing factor statements. That is, you've got to act, and you have to have a process for acting. You have to use implementation science. You can't just analyze. You can't get hung up there you really got to complete the system. And that particular document in RCA squared gives lots of ideas and tools for how to do that. So let me give you one example. I hope that you all have examples in your own incident reporting system where there's been some kind of event or a series of events, and there have been safety reports, and that those safety reports were analyzed, they were remediated, they were tried out, they were implemented, you tracked the difference, and you saw that the events had been reduced or eliminated. And if you're really lucky, maybe you saw some positive culture change as a result. That's pretty tough. So I'm going to give you an example of one event from one hospital. And the event in this case was there had been repeat anaphylaxis events on one patient. That is the first time this patient had anaphylaxis. It wasn't completely documented. It wasn't clear what the process was as to where the responsibility was. Was it with surgery, anesthesia, or allergy? To ensure that this was documented in the patient's record, not just documented, but it was also understood what was the triggering agent. So there was a root cause analysis, and that was realized that that process to identify the agent and the steps needed for follow-up and the documentation really weren't all laid out, and it wasn't clear exactly what was the process, whose responsibility it was every step of the way to ensure that it got documented for that patient. So there was feedback to the people who had reported the event and the people who were involved. There was a thorough root cause analysis. There was a process developed that was cooperatively done with an interprofessional group that involved surgery and anesthesia and the allergy specialists. They created that process, and then they tried it out to see how it worked. They told people about it, and they made some adjustments in the simulation to ensure that the process was going to work, or work as well as it could when it was first implemented. There was messaging, there was training, and this was implemented using good techniques to implement that process. They looked at the effectiveness. Again, for events like this, they're not very frequent, so it's really hard to do that, as you know, in quality improvement, especially when they're low frequency events, to know whether you're making a difference. They were able to track. They widely publicized that the changes that had been made. And really, there had been no new events after that. This event where the same patient didn't have documentation and got a second triggering agent. So this is an example. It's not necessarily a common one. You may be familiar with the general process, but it's an example how you have the full loop of safety reporting leading to system change and harm prevention. Whether it really changes the culture, we can't really be sure at all, of course, but that's what we'd like to happen. So is incident reporting worth the effort and the cost? It's a big question. It's a question mark. We don't really know. There aren't good studies about that. And in this is a chapter. The first author is Oberfrank in the book that I mentioned earlier. And it's a wonderful chapter on human factors. And the quote from here was that despite their current ubiquity, the actual contribution of these systems to any of their stated goals is uncertain, and questions about their effectiveness remain. Again, this is a quote from the chapter, but it's also from, it was quoted from the Mitchell article that I cited earlier. So the conclusion of these authors is that we really just don't have the evidence to show that incident reporting is worth it. That's really troubling, because everybody does it. We all healthcare systems have some form of incident reporting. You can't not have it. So why is this? I mean, I think it's that we can't live with them and we can't live without them. And that's a quote from me, that we have to have incident reporting systems. We can't live without them. On the other hand, we can't prove that they're really worth the cost. As you know, this is pretty common in safety. Safety people are often pushed to give the business case for safety. That's something that's always troubling to me. It's hard to prove the business case for safety. Yeah, you have to have some thoughts about, is what you're doing worth the cost? But to do it at the same level that you're trying to run a for-profit business, to say, is it worth the money to save the life of a patient or employee? I just don't think that that's an ethical thing to do. And this point has been argued often. It's still argued in all of patient safety. My particular pet peeve is I don't think it's fair to push to look for the business case for safety, and it makes it more challenging to do things like build robust incident reporting systems, because it's so difficult to prove whether it really saves money. My root cause analysis for the lack of optimal effectiveness of incident reporting systems is there's a lack of true belief by leadership that the safety affects the bottom line, that they want that business case. That's the conundrum for safety, that you can't prove what you can't count. Also, that resources are often focused on reporting. More effort goes into the actual reporting and the analysis of the reports than should go into the fixing of the system. We need more resources and the will to change systems to prevent errors, mistakes, and system problems that end up in adverse events. There's a lack of engaging safety scientists. Probably most organizations really don't employ or involve safety scientists in learning how not just to investigate, but most importantly, how is it that you implement true safety solutions, including, for instance, human factors experts. There's a failure to use implementation science to affect organizational change. This is a science. This is something you really have to study and learn. There are experts who do this. We need more of this in the safety world in order to close the loop for incident reporting systems. So is there hope? And what can you do? So here are some ideas. Again, I don't have empirical evidence. These are suggestions from my reading of literature and involvement, continued involvement in incident reporting. I don't study incident reporting per se, but I'm actively involved and have been for many years in our own reporting system, the analysis of those events, and the feedback systems, and the closing of the loop to fix things. So this is my general take on what I've read and my experience from this, and that is that you have to train people for the proper use of the incident reporting system. You have to train them not to attack people, not to use it to attack people. You need to develop appropriate prioritization of reports to be acted on. You need to put resources into action and implementation versus just the reporting of an analysis. You need to create teams that include safety scientists, give feedback to all the reporters at different stages of the analysis and the implementation process, and publicize the successful actions and how the problems came to light so that people know when they report something's going to happen, it's worth doing it because we really care about this. So you might want to think, perhaps we should change the name. There's one article I came across where they called it Incident Learning System, an ILS, instead of an IRS or a PSIRS. So you might want to think about that, because I think the idea of safety reports gives this negative connotation that people feel like, oh, if I file that, some people are actually afraid because they think it's going to be used as a weapon, and they don't want to report because they don't want to get somebody in trouble. They don't want to get themselves in trouble. So maybe referring to the learning is really more appropriate instead of highlighting the safety issue. Call it an incident learning system. These are ones that I've made up. How about an opportunities reporting system? Because this is really about opportunities, and we should be encouraging people to think about it that way. Maybe the how we get better system, or the we aren't perfect yet reports, or we all screw up sometimes stories. Those are the WASUs. So these are a little bit tongue-in-cheek, but they get to the point that I think we've got to get people to be thinking about incident reporting systems as being something positive. We've got to build a culture where they don't feel that there's going to be retribution when they report, and that these systems really make a difference. Maybe changing the name is the way to go. My recap is the IRS, the PSRS can be useful, but they aren't as useful as they should be. The culture affects reporting, and the incident reporting system may also affect culture. The incident reporting system needs to be robust, and the emphasis has to be on action. The effectiveness, to be effective, it requires expertise, and we can do better. So I want to thank all of you for tuning in and for listening to this. I hope you'll go back to your respective healthcare organizations if you're not there at this moment, and really think about this topic, investigate and look into and see how you can support the improvement of your incident reporting system. I think it's really worth it's worth the effort for all of us. It's a really important thing to do because incident reporting system is really at the heart of patient safety. So I'll be available for questions and be very interested to see what those questions are. and get your thoughts and ideas about this. So thanks very much.
Welcome back. So we are having our session for Q&A for the next 10 minutes. Thank you very much Prof. Hugo for your very interesting presentation. Okay, I'll start with the one questions here by Prof. Chan. How do we overcome the problem of administrators who feel fearful of sharing the results of the findings, even if all the data are made anonymous?
Yeah, that's a really tough question. I'm not sure what the total context is about it, whether you mean administrators not allowing sharing of information within, say, the department versus them not allowing it to be shared outside. But I don't know why an administrator, I can't understand how they wouldn't allow sharing within the department when there's incident reporting to give the feedback to people in the department. So that doesn't make any sense to me. I understand how hospitals are reluctant to make that information available outside. And I think they should. I think they should be open about it. But if you have administrators, and often it's for legal reasons, that hospitals are afraid to have such information become even possibly public, all you can do is try to educate them or wait for them to leave. And I think it's the latter that's usually the best choice. And you wait till you get lucky, and maybe you eventually you have a period where you get a good one. Because one thing about administrators is they turn over a lot, generally. And if you're stuck with one that's theirs for too long, it's all these things have happened to me. I didn't leave, but sometimes you have to leave, I suppose, if you want to be in a good culture. So there isn't any great answer to that. Informing them, don't try to convince them in one meeting. Have them understand the process. It depends on how approachable they are. And some are just not approachable. But I think educating people about the kinds of things I was talking about in this lecture would be helpful. So approach them and have them watch the lecture. Maybe it'll be helpful.
Yeah, thank you. I think the feedback system, it's not, like what you mentioned earlier, a lot of emphasis has been put into making the report. So they encourage a lot of people to report, but the feedback and the remedial action, the tracking the effectiveness is not there.
Yeah.
So there is no motivation for the reporters to continue to report, because we don't see what's coming out of it, even if we report, and some may be made to write explanation letter, to admit that I've made a mistake and there's medication error and things like that, which is a bit odd.
Yeah.
So, okay, right. The next question is, in medical field, most, if not all, doctors would have made an error in management or judgment, which would have contributed to the mortality or morbidity of the patient. How can we make a discussion about the event without making a blame game, but make it a learning event instead, especially when we are living in an environment where people already are very, very defensive? A question from Professor Ching.
Yeah, this is an absolutely critical issue. It's a really great question. I've been involved in our QA committee since we started it in 1985. So I've been sitting in QA meetings and watching reports come and watching how that process has evolved, where it at the beginning it got people to be more defensive because it was a little more blaming. And as the years passed, the culture shifted. And it has most to do with the leadership, and that the leadership of the committee and the process really understands how important it is to not threaten people, to be helping people who have events. So I think that's the critical thing, is who's leading that process and manages the discussion. So when we have a QA meeting, the person who's running that meeting has to be sure that people who are asking questions, that's the way we hold ours, by the way. We have a meeting, there are a bunch of clinicians of all different kinds, and the people who were involved in the event actually come to the meeting. And when we started that, and for many years, even though the people were pretty sensitive who were running it, the people who were presenting their cases, they still didn't feel good about it. Because sometimes, no matter what, the people who are their colleagues who were in the committee were just asking questions in a way that they just sounded blameful, even though they didn't really mean it that way. It's really challenging. And over the years, I think we've just gotten better and better at it, because the people who manage that are just super sensitive to how vulnerable people are when they've had an event. And we just do so much to try to, we have an entire peer support system. So that's another thing to do. We have that's spread throughout the hospital. The person in anesthesia is the one who started it. She trains people. So having a peer support system might be a way to do it. That is, when somebody has an event, doesn't have to harm somebody, they're contacted and they're given an offer to have a peer supporter. And so somebody who's a colleague, if it's an anesthesiologist, it's an anesthesiologist. If it's a resident, CRNA, registered nurse anesthetist, they talk to a peer and they just chat with that person. And if they need more emotional support, they can get professional emotional support. But usually just talking to their peer is helpful. So in so many ways, showing how you respect how challenging it is and how they're second victims, that people who actually are the clinicians are second victims, is part of making them less defensive. I think all of that you have to really care. And the leadership has to really project that in a meaningful way. But if you mess up once, if the word gets out that some person was dumped on, was not treated well, it really breaks all the trust. And trust is something that's really hard to build, and it's very easy to lose. So you have to be super sensitive. You can't let your guard down. You have to really respect the feelings and the emotions and the vulnerability of people who have been involved in an event. And I think little by little it creeps in, and it never is perfect. People are always worried about what their colleagues are going to feel about them when they've done something that either wasn't right or they feel wasn't right. Usually, my experience, people are beating themselves up more than they should. So sorry, it's a long answer to a question, but it's really the critical question in this. So thanks for asking.
Yeah, thank you. But it's also very difficult it's a culture that we have to change. I don't know how to steer it away from using incident report as a weapon to steer it into a positive safety culture. What do you think? Any advice?
Well, there are two things. One, when you get those negative safety reports, because we see them in our system, it's how do you manage them? So you don't have to take that report at face value. So if you investigate the event and you talk with other people, you talk to the reporter and may have them actually go talk to the person who they're attacking. And so we'll do that, have facilitated conversations because they're really interactions with people that are problematic. So that's the first thing, is when somebody files a negative safety report, when they're really blaming somebody, they'll, when it happens, it'll often get feedback from the person who's in our team who's reviewing those reports and let them know, hey, maybe that wasn't a great way to do it. Or the person in our team will edit the report out. They'll redact it to make it less blameful, so that when other people in the, because those reports aren't made public, but they're seen by people in the incident reporting system, the hospital system. So, it's to try to lessen the negativity there. So two things. It's the way you use the report. Don't take it at face value. Give feedback to the people who are filing those reports, but also do training. And I mentioned that in the slide. Train everybody to how you fill out an incident report. Don't use it as a weapon. That's not what it's intended for. So you have to do training about the whole system and how it's used.
Yeah. Okay. Yeah. Unfortunately, training for the IR, it's never in the curriculum throughout the whole master program, and it's something that we learn on the job as you go through. As you receive so many IR, then you start to learn, okay, what is the process about and how do we go about this? So
the person who runs our system actually meets with all the residents, and she tells them about the whole quality and safety system, including how to file incident reports. So when the residents come in, they are given some instruction. Who knows if they really, how much they remember in those early days. But when they may not file a safety report for a year or two or ever. But when they do file it, they may or may not remember. But we do try to give them instruction.
Okay. So I think we have probably a few seconds left. So thank you very much, Professor Dr. Jeff Cooper, for your very interesting session. And hope to see the rest of the participants in the symposium to come. Thank you very much.
Thank you. Thanks, everybody. Good night.